Good afternoon, everyone. I promise I am here, even though you can't see me, and I promise it is me. So as Jeremy said, earlier on this year, we went through a mumps epidemic. And I can certainly speak for myself, but I think a lot of people have got pandemic and epidemic fatigue. So when this came around, we were almost like, thank goodness it is only mumps, not that much mortality and morbidity. And in fact, as a result, we tend to not pay too much attention. So speaking for myself once again, and when this occurred, I just realized that, there were a couple of questions that were not quite at my fingertips. And so this is what sparked this talk. So NICG confirmed the outbreak on the 11th of May. And so this had been going on. This graph is from this is looking at their results that from 2013 all the way up to 2023. And for 2023, it was up to the 31st of March 2023 that they had results for. So they looked at what they had received, so requests for mumps serology, and then they looked at their positivity rate. So that's that red line that you see across there. And you can see that, the highest positivity rate was previously in 2019, that was sitting at around 40%. And at this stage, for 2023, just that short duration, we were straight up and vertical and sitting at around 70%. And so they actually sent out this bulletin on the 11th of May. But on the ground, we had been feeling it for months already. We knew we were having something happening. It was just everywhere, it was going through the schools, whether it was public or private schools. The kids were coming home, infecting the rest of the household. And in fact, the rumor line on just lay people were saying that this is caused by the measles vaccine that they were getting. So this happened to coincide with the outbreak response to the measles outbreak that had been happening. So there was measles vaccination as a response to that. And this happened coincidentally at that time. So people started believing that it was the measles vaccine that was actually causing the mumps outbreak. And looking further on in terms of just looking at 2022 to 2023, this is a breakdown by provinces, and you can see that KZN completely predominates there. So this talk, apart from just the mumps outbreak, is dedicated to one of my colleagues who then got mumps during this period and went through quite a rough patch and even got one of the complications of mumps during this time. So this is what I'll be covering in the talk, just to refresh our minds about mumps. So mumps is an acute viral infection caused by the rubella virus, also called the mumps virus. It goes via many names. It's also called infectious parotitis or infectious non-suppurative parotitis. And it is also called epidemic parotitis. So the pathognomonic feature of mumps is the painful swelling of the parotids and the salivary glands. And the first description, written description of mumps was actually in the 5th century BC by the father of medicine, Hippocrates, where he described an outbreak of mumps on the Greek island of Thessos. So went the description. Swellings appeared about the ears, in many on either side. and in the greatest number on both sides. The description continues. They were of a lax, large, diffused character, without pain or inflammation, and they went away without any critical sign. So, I mean, this is still literally what the clinical diagnosis of mumps is like. And I'm not so sure about the pain aspect of it, because every description that I've read about it is highlights that it's got quite severe pain. Though, you know, come to think of it, the kids that I saw during this time, you know, they had discomfort, but they were not in excruciating pain or in severe pain or sort of thing. So, and throughout the ages, you know, mumps has caused many epidemics. It's got this nature of causing epidemics because it's highly infectious. The viral etiology of mumps was discovered in 1934. So Claude D. Johnson and Ernest William Goodpasture, they took saliva from infected children, so in the early stages of the disease, and they infected macaque monkeys. So when these mumps then went on to develop parotitis, they then killed the monkeys, but they macerated the parotid tissue from the monkeys, and they filtered it and sterilized it with a filter that would filter out bacteria. And then they infected children with this macerated, sterilized parotid tissue. And then the kids went on to develop the disease. And from that, they induced that it is actually caused by a virus. And the actual virus was then isolated in 1945. Soon after that, that paved the way for the development of the first vaccine in 1948, which was an inactivated vaccine, which was not that effective. The first live attenuated vaccine, called the Mumps Vax, was developed in 1967. And what we are currently using now, the MMR vaccine, which is combined with measles and rubella, was registered in 1971. So looking at, I mean, we go on mumps, but why is it called mumps? So the word mumps started circulating around the 1600s, and it is a plural form of mump, which at the time meant grimace. And the word grimace itself meant to mutter, to whine or mutter like a beggar. And mumps then started being used in the 17th century. And the word at that time meant a fit of melancholy, sullenness, or silent displeasure. And it is thought that the disease itself was likely called mumps in reference to the swelling caused by mumps parotitis, which reflects its impact on facial expressions and the painful, difficult swallowing that it causes, as you can see on that picture. So mumps is caused by a single-stranded negative sense enveloped RNA virus, which is belonging to that family there, the Paromyxoviridae. And you can see what other viruses belong to that family, and then you've got mumps there. So it only naturally infects humans. So the humans are the only natural host. And transmission is via droplets of saliva or respiratory secretions, and also then indirectly via contact with contaminated surfaces. The incubation period is between 16 and 18 days, generally, after exposure, but it can be anything from 2 to 4 weeks. The infectious period is, so if we look at the characteristic feature, which is the parotitis, and that's when everybody says, aha, I'm dealing with mumps. The infectious period is 7 days before the appearance of the parotitis and 5 days afterwards. So at infection, this virus replicates in the upper respiratory tract, and from there it then spreads to the salivary glands and continues to spread to lymph nodes and then on to the bloodstream. So this is also the period under which that you then quarantine the person when the person has got, or isolate the person when the person is diagnosed with mumps at the seeing the parotitis. Those 5 days afterwards is the general period that the person is infectious for. This is largely a childhood illness. So it infects school-aged children, and the median age is between 5 to 9 years. It can also affect adults. So the second biggest group in terms of the commonest age group that is affected is young adults, especially in congregate settings where adults are either in military or in university, those kind of congregate settings. And interestingly, if the adults are symptomatic, because up to 30% of patients with mumps, whether they are kids or adults, can be asymptomatic. But looking at all those that are symptomatic, adults tend to have more severe symptoms and more complications compared to symptomatic children. So I think this is another example that, you know, when all things being equal, when we are all equally susceptible, kids tend to handle all of these viral illnesses much better than adults. And I think this was also shown during the COVID pandemic. So generally, infection confers a lifelong protection, but there are rare instances where patients have been infected again, so a second occurrence of mumps after they've had a natural infection. And very rarely you can get patients that get recurrent parotitis. So they would get the first episode of mumps unilaterally on one side, and then ranging from weeks, and then that would resolve completely. Then weeks to months afterwards, you know, they get parotitis again on the other side. It can occur in fully vaccinated individuals. Those people that are fully vaccinated tend to have less severe symptoms, and there's a lower incidence of complications comparing unvaccinated to fully vaccinated individuals. So the clinical presentation, there's a prodrome of headache, fever, loss of appetite, fatigue, myalgia, and ranging between 1 to 48 days. Later on, you get the characteristic appearance of the parotitis. That can be associated with orchitis on the same side as the parotitis. Then over the next few days, you get this progressive swelling of the parotids and severe pain. And this would then continue, and then you get complete resolution, anything from 7 to 10 days. So looking at this characteristic feature of mumps, it's the parotitis. So in 60 to 70% of infected individuals, you get parotitis. And in the majority, it is bilateral. So only about a quarter will it be just on one side. And then the rest of the salivary glands are involved in 10% of patients. So if we're to look at the differential diagnosis of the parotitis itself, we've got other viral causes of parotitis and quite a long list of viruses. And if you look at some of the viruses there, for example, with HIV, it's not generally acute and it's not generally painful. So that would be quite easy to differentiate it there. So those other viruses can also cause painful parotitis, but they would be associated with other features as well that would help you to differentiate between one and the other. Then if we look at bacterial causes of parotitis, we've got a suppurative parotitis, and the usual pathogen there is Staph aureus. And in that particular one, you can differentiate it with getting pus coming out of Stensen's duct. Then you've also got non-infectious causes of parotitis. And then there's a list there from salivary gland stone all the way to Sjogren's syndrome and sarcoidosis and salivary gland tumor. And there are some differentiating features there because you may not have the characteristic acute, painful, and as well perhaps an epidemiological link. You're not going to have it in non-infectious parotitis. And of course, it has to be differentiated from just lymph node swelling. And that can easily be done by the examination because lymph nodes are generally discrete. Whereas if we go back to Hippocrates' description of parotitis, then this is going to be quite diffuse. So the complications, I've divided them from the common to the very rare complications. So the common complications are meningitis, encephalitis, and orchitis. And then there are some rare complications that I was and even the very rare ones, I was finding them out for the first time. So deafness, and in fact, in the first world where they do MMR as part of their immunization schedule. So prior to the introduction of MMR with these mumps epidemics that were occurring, mumps was the commonest cause of acquired sensory neural deafness prior to the advent of the MMR vaccine. So the other rare causes are then pancreatitis, you can get a Guillain-Barré syndrome, and you've got the list there going down. Very rarely you can get, so mumps essentially it looks like can cause just about anything. And then extremely, extremely rare is then a death from mumps. So if the one complication that I recall from a medical school, or maybe this is just me, is the orchitis. You know, everybody was concerned about this orchitis that you get from mumps. So it is the most common complication. And interestingly, it only occurs in post-pubertal males. So in 20 to 30%, it will occur in post-pubertal males. And it occurs with a lower incidence in those that are vaccinated. So occurring only in 6% versus the 20 to 30% of post-pubertal males with mumps. And in a large majority, it is unilateral involvement. So it looks like, you know, this fear of sterility as a result of mumps is largely unfounded because 60 to 80% is going to be unilateral involvement. And testicular atrophy has been reported in 30 to 50% of unvaccinated males. And so even if you do get the testicular atrophy, because largely it's occurred in one testis, you still got the other testis there involved. So then the one thing, there's been a lot of studies that have tried to look into this, and sterility is exceedingly rare as a result of mumps, but you can get hypofertility when you've had a bilateral orchitis. So earlier on, I mentioned the fact that, you know, there's not much morbidity or even mortality as a result of mumps. So even this really commonly feared complication of orchitis leading to sterility, it seems that, you know, it's much of a muchness. You don't have to worry about that at all. Then if you do develop the orchitis, then because some patients, you know, may not actually even have the parotitis at the time that they get the orchitis. So looking at the differential diagnosis for orchitis, it is the differential diagnosis of epididymal orchitis. And you can get other viral causes of Orchitis, same long list of other viruses. And then bacterial causes would be STIs, and then the enteric organisms. So looking at the neurological complications of mumps, so if we look at encephalitis, deafness, and meningitis, they are the most common neurological complications. And amongst the neurological complications, meningitis is the most common neurological complication from mumps. I've already mentioned that prior to the advent of the MMR vaccination in the first world and increased coverage, that sensory neural hearing loss, acquired sensory neural hearing loss, was mumps was the commonest cause of this. But even currently, then, the most common cause of viral meningitis or encephalitis in the first world where they are using MMR is mumps. So you can see kind of their rationale of having MMR as part of their immunization schedule. So if we look at meningitis, it occurs in 1 to 10% of patients with mumps. There seems to be a male predominance, and no one knows why there is a male predominance, 3 to 1. And the strange part is that, it can occur before, during, or after the parotitis. I mean, during the parotitis itself, it's easy enough. But the ones that are occurring before or after the parotitis, then it makes it difficult to say, is this just mumps parotitis, and I can predict what the prognosis of that is going to be. And in some cohorts, up to 50% of patients have had mumps meningitis without the parotitis, no parotitis at all. So this makes it difficult then to say, it is mumps parotitis just clinically. So it presents like any other meningitis with a headache, low-grade fever, and nasal rigidity. The CSF picture is predominantly that of an aseptic meningitis or viral meningitis. So with anything from 10 to 2,000 white blood cells with a lymphocyte predominance. Though early on, you get the predominance of polymorphonucleosides. The total protein is usually normal, but it can be slightly elevated. And the glucose as well can be mildly decreased. And there has been reports of a glucose as low as 1.7 with mumps parotitis. So if you are in that group of patients where there is no parotitis, or it's occurring before or even after, given that we don't do the investigations for viral pathogens on CSF as a routine, this can be a bit confusing. In terms of the prognosis, it's a very benign cause, and there would be no permanent neurological sequelae. And if you look at encephalitis, it pretty much presents this in a similar manner with headaches, with a loss of consciousness. There may even be seizures or decreased level of consciousness, like any other picture of encephalitis. And going through this, it just made me wonder, how many patients with mumps without the parotitis are we diagnosing as, bacterial meningitis where we can't culture anything, or even more commonly in our setting, we are diagnosing them with this lymphocyte predominance and maybe slightly elevated protein as TB meningitis. But be that as it may, I'm happy to overtreat a couple of TBMs, when they've actually been mumps without proving that it is TB meningitis, because in our setting, we have to think of TB and treat TB, because TB is not going to have the benign course that mumps has. So looking at diagnosis, so this is from the NICG case definitions for mumps. So the first column there on the left, so a patient with suspected mumps. So this would be a patient that presents with acute parotitis or any other salivary gland, or can present with orchitis or orchitis. I'm not quite sure how you're going to diagnose the orchitis. And then, you know, or a positive lab diagnosis. With the lab diagnosis, it's important to remember that you can get false positives and even false negatives from the serology, especially with EBV. A probable case would then be a clinical case as defined previously, and a patient then with a positive serology or an epidemiological link to a confirmed or probable case. And then a confirmed case would be all of those with now a molecular diagnosis or even culture-based methods where you've actually definitively proved that this is mumps. So for serology, you can send off mumps antibodies, and the lab would then measure IgM. And also, you can also get a 4-fold increase in paired IgG antibodies. This is taken 2 weeks apart. So this is done at NHLS immunology lab. And for us here, we would, in Gauteng, we would just label it as going to Braamfontein Immunology lab. The molecular diagnosis is with a PCR for mumps RNA, and salivary is the best specimen in uncomplicated cases. But you can also do a PCR on other clinical specimens. So a patient with meningitis, you can do CSF, and also you can get it from blood. And it is important to just keep in mind the duration of viral shedding. So just a few days prior to the appearance of the parotitis, if you are dealing with parotitis, and then the 5 days afterwards. And outside of those periods, you start getting a significant decrease in viral shedding, and so you can get negative molecular tests in those patients. I don't think you can do viral culture, but I mean, what's the point when you can do a molecular diagnosis? So for the molecular test in NHLS, it goes to the virology lab in Tygerberg, but in private, both serology and the molecular tests are available in any of the labs. When it comes to management, there is no specific management for mumps. So the management is largely just symptomatic with bed rest, fluids, analgesia, antipyretics. The IPC measures are important, keeping in mind the isolation period, and that you need to practice droplet and contact precautions. For prevention, the main prevention is actually vaccination. So there is no post-exposure prophylaxis. There's no mumps immune globulin. You can't give polygam in terms of post-exposure prophylaxis. And you shouldn't as well be vaccinating as part of a post-exposure prophylaxis. If we look at who is at highest risk in terms of getting mumps, it's those that are unvaccinated, people that are in congregate settings, and then overcrowding. So in the first world, and CDC has got these guidelines where in an outbreak setting, you can vaccinate those that are at highest risk. And those that have been previously vaccinated, you can even give them a third dose. And if the person has never been vaccinated, and you can start vaccinating them if they're at high risk and they are in this group of people that are at high risk if it's an outbreak. So patients that are undergoing transplant, so because MMR is a live vaccine, so you can't give it post-transplant. And you also want to avoid post-transplant patients during the immunosuppression, getting mumps, and then even getting organ rejection and all of those other complications. And because they're immunosuppressed, perhaps getting even more complications. So patients that are going to be undergoing transplant, one of the vaccines that they can be considered for and reviewed for is to vaccinate them with MMR prior to their vaccination, so that post-vaccination, then you don't have to worry about that as much. So coming to the MMR vaccine that is currently in use. So at the moment, there is no single mumps vaccine. It only comes in the MMR vaccine. It is a live attenuated vaccine. The first dose is given anything from 12 to 15 months of age. And then the second dose from 4 to 6 years of age. And the adverse event that you can expect is parotitis. And of course, you've also got the measles and the parotitis and fever, and you've also got the measles and the rubella. So you can also get a rash as a side effect of the vaccine. So interestingly, both fully and partially vaccinated people can get infected and transmit. So it's not a very efficacious vaccine when we're looking at the mumps aspect of it. So what would be the benefit? Why vaccinate for mumps at all? So we have mentioned kind of in the first world what the epidemiology looked like in terms of the side effect or the complications, neurological complications of mumps for them. Now, one of the benefits is that you do get a lower attack rate in fully vaccinated versus unvaccinated people. There's decreased severity of the symptoms, and then there's less complications. And studies that have looked at the vaccine efficacy after 2 doses, it's 88%, and after 1 dose is 78%. And so to sustain disease elimination, you need quite a high vaccine coverage at 95%. So coming back to the mumps epidemic that was experienced just beginning of this year in South Africa. So this is the last update from NICG. So you can see that as expected, we don't expect to have a difference in the gender. So male and female pretty much accurate, equal. And the age, median age was 6 years, as described in the literature. And the predominant age group that was affected was the 5 to 9-year-olds, 58%, followed by 1 to 4-year-olds. And it is very rare in kids that are less than a year because of the maternal protection that they get from transplacentally transferred antibodies from their mothers. Then so also the other thing you have to remember is that, the data from NICG is very much an underestimation, even from 2013 all the way up. So yes, there's a comparison from all the years, but all the other years are just as much of an underestimation as 2023 is, because all the cases that we saw at Bara, we never sent any investigations for them. So it's largely a clinical diagnosis. And so they analyze only the specimens that had been sent for mumps as serology. Yeah, and then the provinces, once again, it's KZN that bore the brunt of it. Whether they were just sending lots of investigations, because when we were in the thick of it, we felt like we were not experiencing only 11% in Gauteng. And this update is at the end of May from NICG, and that's included data now up to the end of April. The previous one that I showed you was up to the beginning of April, no, 31st of March. This one is up to the end of April. And we can believe that, it has, the positivity rate has come down because we are not seeing mumps anymore, even though this is an underestimate given that, people don't necessarily send the investigations. So everybody can express later on whether they also are feeling the same thing. But on the ground where I work, certainly it seems to have, we're out of the epidemic. So why is it then, that you can get this recurrence of mumps, and why did we experience a mumps epidemic? So mumps is highly contagious, and we've mentioned that over the centuries, it is epidemic prone. And even post vaccination, it tends to cause these epidemics. And in the vaccinating countries, they've looked at what could be the reason why they are still getting these epidemics of mumps. The one is genetic heterogeneity in vaccine response. Also, it's thought that the vaccine-derived antibodies are not as effective as the antibodies from natural infection with mumps. You do get waning antibody titers as well. Sort of, if you've received your 2 doses, by 27 years, they are all completely gone. And of course, they are waning throughout that period. And some people are even advocating that this is the vaccinating countries. They should be giving a 3rd dose of MMR at 18 years. You also get then limited exposure, and that limited exposure can cause decrease your immunologic boosting. Because if you are fully vaccinated and throughout you are getting this a little bit of exposure, but you are asymptomatic or you are having mild disease, that would actually boost, almost act as a vaccine booster. But you are getting a booster from a natural infection that's less severe or asymptomatic. Now, the South African private sector, which is a very small component, patients do have access to MMR privately. Anybody can get it privately. So if you look at this current epidemic, it was both in the private sector and in the public sector. Now, in the private sector, all of the above reasons would account for why we had a mumps epidemic. But also, if you look at the pre and even post-COVID kind of behavior, I mean, pre-COVID, there was a slump in the economy, and it continued through COVID and post-COVID. And so because people have to pay for this, is it probable that, people just didn't go for this vaccine? So dropping MMR vaccination rates. And it's also probable that, during COVID, no one would be taking their child who is 1 and even above that for the 2nd dose, for the 1st and 2nd dose of MMR. And of course, human behavior is been seen that, you get this drop in vaccination rates the older the child gets. So highest in infancy, and it just starts dropping from there. So is it that most people had just partial immunization, only had the first dose? If we look at then the rest of the South African population where, the MMR vaccine is not part of the extended program of immunization, you could ask, why is it not being offered as part of the extended program of immunization? And this relates really to the other M and the other R. So if we start off with measles. So measles causes high mortality and morbidity, especially when acquired early on, less than 2 years of age, and even more so in infancy. And in South Africa, when acquired in the setting of the comorbidities of malnutrition and untreated HIV. We're winning with the HIV, not so much the malnutrition. I mean, we've had a huge resurgence of malnutrition. So we still have these epidemics of or pandemic of malnutrition, and then the HIV is much better than previously. So in South Africa, we want to get in early to try and give these kids protection. So we vaccinate at 6 months and at 12 months. We also want to get in very early because we know that there's this waning vaccine coverage from 6 months onwards and beyond infancy. So that even though the 6-month dose is not going to be very immunogenic, it does offer some protection, and then we boost at 12 months. And the measles vaccine the vaccine efficacy is, greater than 90%. It's 99 kind of percent. So we then covered for a condition that has very high mortality and morbidity. Then we look at the R, and the concern there is congenital rubella syndrome. And rubella is generally in our third world setting acquired in early on with young kids in nursery schools and other young kids. And it's very much a mild, benign infection. And so most women of childbearing age, acquire rubella in nursery schools when they are very young. And by the time they reach a childbearing age, they've already got a natural immunity. And if we were to introduce MMR, we've already gone through the poor vaccine coverage that starts waning beyond infancy. And remember, the MMR, you can only start at 1 year, and the booster dose is at 4 to 6 years. We don't want women of childbearing age getting primary rubella infection during pregnancy, which would then increase our incidence of congenital rubella syndrome, which there's nothing you can do for it, permanent neurological and even the cardiac complications that you get from it that define the syndrome. And of course, the last M is mumps, which is also a mild benign infection. So hence in South Africa, really, we have to balance all these different things in looking at, do we target mumps as in trying to control the epidemics. So yes, that is the story of mumps. I'm open to questions and comments, and thank you very much for your attention. Short and sweet.
Perfect. Thank you very much, Nosisa. That's fantastic. Really, really nice overview. We've got quite a few questions. Some in the chat, some have been messaged to me. First one is from Kim. She's saying that she had many adult patients with mumps, meningitis, and encephalitis during this latest epidemic. The neurologists were very keen to use corticosteroids. Do you know of any benefit or any indication for steroid use?
In everything that I read, there was nothing about corticosteroid use during with mumps. It is patients get better without anything. And I think the only other thing that, is just being sure that it is mumps, especially in those patients that have no parotitis associated with it. But other than that, it is just completely supportive treatment. In fact, we also encountered a few people where the neurologists were treating the patients for bacterial meningitis because they just picked and the patient had already had mumps completely confirmed, and then they went on to develop meningitis, and they had that nucleoside predominance, and the neurologists decided to treat for bacterial meningitis even though it was negative for bacteria.
Cool. Kim, Lauren is asking, were any of the patients who you saw vaccinated?
So the patients that I saw were in the public sector, so they were unvaccinated. But I think, having gone through everything, we now know that you can get it even if you are fully vaccinated. We now know about the waning immunity and all these different aspects. And also just looking at that factor that, that first dose, is not going to be very efficacious. You need the second dose. So looking at whether this was they were partially vaccinated versus fully. And of course, with the adults, you were sitting with people, even if they'd had the 2 doses, that would have had waning immunity. Yeah.
Cool.
So perhaps the people in private would be able to comment on, the vaccination status of the people that actually got mumps.
And Nosisa and Jeremy, it's Kim speaking. So most of the patients that we had, adult patients who got mumps and mumps encephalitis, had had a measles vaccine, but most of them had not had an MMR and weren't immune to mumps. So it was really interesting to me to see how many of sort of our parents' aged people and maybe my age people had not had an MMR. And so, and have never had mumps as children, and so are at quite high risk for mumps.
Yeah, very interesting, Kim, because I think also when I became interested in this, there were some adults that had then gotten mumps, and they were like, but I was fully vaccinated. And then I didn't have the ready answer in terms of what is the vaccine efficacy, how long does it last? And of course, they would not necessarily remember whether they were partially or fully vaccinated. But the one person, I was pretty sure they were probably fully vaccinated because they were not even born in South Africa. And they were from a country that kind of vaccinates. So that was quite interesting.
Yeah, really. Judy's asking about when you have a patient who has obvious mumps, parotitis, but also meningism, do you think an LP is also necessary? She's asking, like, does the LP relieve the headache a bit, or would you, because given that it's self-limiting, do you think an LP would still be indicated?
I don't think so, because I think there's nowhere where it talks about, the LP itself is quite traumatic. The LP itself is absolutely traumatic, and there's nothing anywhere that talks about doing therapeutic LPs, or even that you get raised intracranial pressure, and that's why you are having a headache, and therefore you should do LPs for that. I don't think so. I haven't read anywhere that talks about that.
Yeah, I guess the only thing would be to rule out other possibilities. But as you say, when you're coexistent with parotitis, that the likelihood of it being not something else is quite low. I guess it would have to be a huge coincidence.
Yeah.
And then there's a question about, do you know if there's prolonged viral shedding in immunodeficiencies?
Well, no one knows, hey, because a lot of the research was done when there were, like, mumps was in the first world, predominantly when mumps was extremely prevalent. So at the time, we didn't have the HIV epidemic. A lot of the research was done 50s, 60s, 70s, just prior to them introducing MMR. So we didn't have HIV as a cause of secondary immunodeficiency. And also we would not have had these extensive transplant programs and even biologicals. And so in South Africa, there is no research really on mumps looking at, I mean, we just largely not that interested, in mumps because it doesn't cause much morbidity and mortality. I work at the HIV clinic at Bara, so we saw quite a lot of patients there with mumps as well, because everywhere else there were patients with mumps, general outpatients at Bara and everywhere else. And none of these patients had any kind of more severe symptoms or any of the complications. So from their clinical course, it was no different from what is expected, though, of course, we didn't measure how long they were shedding for.
Yeah, I agreed. And then I'm just looking down the chat. There's a question about, does measles vaccine predisposed to mumps in any way or to severity? I don't think so, right?
It shouldn't at all, and I think, the mumps was around, firstly. So even if there wasn't an outbreak response with measles vaccination at the time, it would have gone through. So, and just spread all over, because you had this susceptible population with a highly contagious virus. Then, and the second aspect is that now you've got this highly contagious virus, and then you get people into these congregate settings where they're already at school and everywhere else. And by that time, everybody wanted to kiss and love each other and share all the secretions. So none of the pharmaceutical measures in terms of droplet precautions. But it's also likely that bringing all of those kids together to vaccinate them for measles, with a few kids already in there who may have been in the pre-symptomatic phase, and infectious, that's another thing that just created that coincidence.
Yeah, no, agreed. Colleen Bamford's asking about how to deal with outbreaks in schools.
So in schools, so in the first world, they describe quite a lot of this because they're extremely concerned about mumps. So the easy answer is anybody who gets the parotitis, then they have to be isolated and not come to school 5 days. Then you've got to look at, what is the infectious period of once you've got the outbreak that has occurred. So you are also looking at people that could be at high risk. And with those people, perhaps they should not be coming into the school being exposed. Because then by the time you've picked up that there are patients that have got the parotitis, they've already been infectious prior to the parotitis and they are kind of spreading it around. So anybody that you are really concerned about, they shouldn't be coming into school I mean, it's a mild illness. So even if you are high risk and you are unvaccinated, but maybe if you are a post-transplant patient, you are on biologicals or for any other reason, then, you would be quite concerned about that person coming into the school. And of course, that person, you can't now give them a live MMR vaccine to try and protect them. And you also have to consider then that, you have to look at that quite wide period, that is the incubation period of people that have been exposed and they could still potentially develop mumps. So for me, it's almost like look at the simplest kind of scenario. Those that have already got it, they mustn't come to school for the 5 days.
Yeah, that's probably good advice. As you say, it's hard, given that I think you said 60 to 70% of cases have parotitis, so a large proportion don't, and then viral shedding before even the parotitis starts. So I'm not sure how effective all of this is. But as you say,
and then you've got the incubation period that can go all the way up to 4 weeks.
Yeah. But I mean, as you say, I mean, I don't doubt the wisdom of saying, if you have parotitis, go home and come back, 5 days later. I think that sounds sensible, but it's a bit like COVID, I guess. It's always unclear how much public health benefit, that happens when when you can be shedding virus for a long time before, especially given that it's not a severe disease in the overwhelming majority of cases. But I agree. I mean, that is the standard advice, I think, still, as to 5 days after parotitis subsides, I think. Okay, are there any other questions? Because I think that was this, Diana, he says best to get it as a child anyway. True, definitely. I'm glad you mentioned Orchitis, Nosisa, because it's every male's worst nightmare. Okay.
Yeah, no, males are just sissies, worried about nothing.
You needed, yeah. Clearly, none of our parents had bad mumps. Okay, or at least before we were born. Okay, cool. Thank you very, very much. I'm going to pause it there, but thanks, Nosisa. That's a really nice overview, and I think we've learned a lot and kept up to date. And it's good that it looks like the current epidemic subsided. And I suppose that, as you say, without it being in the public sector vaccination program, understandably, given the limited public health benefits, the country's always going to be a sitting duck for mumps epidemics, with resurgences at various times. So I think it's good to know at least a bit about it and some tips and tricks, and you covered that really, really nicely.